This is Ike Ahmed,
And I'm Arsham Shaybani.
and we want to welcome you to GT the Podcast
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to another episode of Survey Says with Dr. Paul Singh. On this special edition of GT the Podcast, Dr. Singh presents a real patient case from his practice and asks his guests to share how they would approach it. For this episode, Dr. Singh met with Drs. Aaron Seek and Arkady Yadgorov to get their perspectives. The patient in today's case is a 57-year-old man with myopia, elevated IOP, and a family history of glaucoma. The patient is on 4 classes of medication and has an IOP of 39 in the right eye and 32 in the left eye, with visual field loss in the right eye. He has not previously undergone any ocular procedures. The guests share their initial thoughts and concerns about the patient and weigh their options for next steps. They discuss whether the priority should be to reduce the IOP or reduce the medication burden, and whether they would begin with an angle-based procedure or subconjunctival procedure. Later, they compare their opinions with the results of a social media poll of GT's audience. Then they find out what Dr. Singh did and how the patient has fared. Tune in to Survey Says with Dr. Paul Singh.
All right, everybody, welcome to another episode of Survey Says. I'm Paul Singh out in southeastern Wisconsin, glaucoma anterior segment surgeon, and I'm excited to hang out with 2 awesome surgeons. One is from WashU, Aaron Seek. What's up, Aaron?
Hey, how's everyone doing?
Good to see you, man. Good to hang out with you. I'm so happy you could join us. We're going to have some fun discussions. And, of course, Arkady Yadgorov down in Atlanta, private practice.
Thanks for having me on, Paul.
Oh man, dude, are you kidding me? It's gonna be so much fun hanging out. This is what I love about these things, just to hang out with friends and learn about cool stuff. And it's really kind of fun. This is a podcast that really allows us to take a real case. These are all real stuff from my practice. Talk about kind of what I do and talk about the vignette and ask you guys what your thoughts are. And then we just look at the polling from the audience in the world of social media. We look at kind of Twitter or X and of course Instagram and LinkedIn and say, okay, is there any differences between those different populations, and just talk about what the audience would have done. And that's it. That's glaucoma. Sometimes no right answer. Before we get into the case, I'd love to just kind of hear about you guys. Tell me, if you just don't mind, what's the 1 or 2 most exciting things that you're looking forward to now that you've seen, whether it's surgical or diagnostic or anything? I'm just curious, Arkady, what do you think? What's exciting to you right now?
For me, I think the most exciting is the idea of home tonometry. What I found is that it sometimes can be hard to discern for a certain patient. Do I need to operate? Do I not? Is the pressure really that high? Is it not? And you get so much of a picture when you get diurnal pressures at home, and patient brings that data in. You go, oh, well, this is a no-brainer. We need to do surgery, right? And the whole concept of checking pressures 2-3 times a year made no sense to me. So to me, I think the biggest thing that excites me is the concept or the technology of having multiple pressures measured over time outside the office.
Yeah, I mean, think about what they did with the diabetic world. I mean, too, with the kind of 24-hour monitoring and the patches. I mean, it changed, it revolutionized the practice of diabetic, follow-up, just because now they understood what foods trigger, what time of day triggers, and they never knew that until then. So I think that's a really good point, man. I think we're learning so much more about even our surgical interventions and what works and what helps flatten that curve out. Let me ask you, before we go into Aaron's question or Aaron's comments, the pushback people always say is, well, let's say iCare Home or other technologies, Rebound, et cetera. Let's say they're not as accurate as Goldmann. To me, it's not about the exact number. It's more about the delta and the, right? I mean, tell me about that. Talk about that.
Well, for me, the biggest issue I have is I'll have patients come in and you can see that their nerve is maybe getting a little worse, or maybe there's a field and the pressure's like 16, right? And then you wonder, and the patient's like, well, my pressure's okay. And then you sometimes see them every few months and then finally get a pressure of 22. And had you gotten an iCare Home tonometry that showed that fluctuation 6 months ago, you would have maybe, taken that leap and done the procedure 6 months prior and saved field versus 6 months, 9 months later, and you go, oh, there goes that peak IOP. And why did we have to see you only 2 or 3 times over the next 9 months when we could have gotten that data sooner? I think they go hand in hand with the whole interventional mindset, which is it's just a lot easier as a surgeon to go, I need to operate when I get a bigger picture of what's going on at home. And just like you said, it's not the actual data point, it's what's going on at home. Is it ups and downs? So feel pretty strongly that that's going to be a huge next step in glaucoma.
Yeah, one of the earliest patients I did the home tonometry was a patient who was kind of slowly progressing despite normal pressures, and he just found before and after SLT just the amount of fluctuation. And yes, it wasn't numerically exactly the same as Goldmann, but you got the same principle. You knew that there was less fluctuation, and that was the key for me. And it's so much more enlightening for some of these patients.
I was going to also say off of that is I think people then don't become obsessed with a single number. Patients get
Right.
really disappointed if you're post-operatively, you don't get down to 12 and you say, it's not necessarily about, like you said, that single digit. It's about the trend. Your pressure is doing so much better. So it kind of takes away the stress of just getting that perfect in-office pressure post-operatively to make the patients have a good experience.
Yeah, really good points. Really good points. Speaking of that, Aaron, talk about what's exciting to you in your world.
I mean, my goal, I love the thought of interventional glaucoma. Obviously, we need to intervene on these patients sooner and sooner, but I'm hoping to catch the people that are going to be fast progressors and slow progressors. And we always go for we need a pressure goal of 10 for these really severe glaucomatous patients, but can we find the ones that don't ever actually need that pressure of 10 and don't need to go that low? So I think that's the exciting thing. And we're working on some stuff at WashU to potentially find a marker that's a sign of retinal ganglion stress. That is a sign of if this patient's actually progressing rapidly or not.
I love that. I love that. There's some biomarkers right now that's showing up as new fundus camera that just came out that's allowing us to look at flavoproteins and the expressions of basically stressed out mitochondria that
Exactly.
can tell us even before we lose nerve fiber layer, even undergo apoptosis. And I think that's going to be exciting stuff because you're right. I think we need to know which patients are truly at risk. And even after our treatments, we don't really know, have we done anything to decrease the stress of those cells right now, unless they have nerve fiber layer defects over time. And to show it real time, hey, that would be awesome.
That's a good point. So we can let the mitochondria be stressed and not us.
Yes, I
Yeah.
like that. There you
Catch
go.
it first.
It's a new song idea.
Yeah.
Well, actually, along those lines too, there's another company I've been using a lot too. It's Sionix Bio. It's a genetic testing, but it's really kind of helpful, like along the lines of what you're saying, stress out cells, which patients might be fast progressors, which patients are fluctuating. You see this kind of like all of a sudden these patients who have these markers of genetic markers now that really are putting them at a higher risk. It's kind of helping again, all these different things, just helping us pull the trigger or not. Should we be more aggressive? Should we not? And I mean, you're down with Arsham right down there. Arsham is famously said, do we have to get pressures below physiologic IOP? He's like, he keeps saying how we're one of the few subspecialties that pushes pressures and pushes our pressures below the physiologic levels to 5 or 6 or 8, where it may not be. It's just more flattening that curve if we can. So good stuff, guys. And so with that said, we got some cool stuff in our armamentarium. And so I'm going to take what you guys have said and talk about a case. And I'd love to hear your thoughts on this case, guys. And then let's see what the audience picked as well. So it's a 57-year-old myope, -6 myope, white male, actually with referred for an outside OD, but patients on 4 classes of generic meds, timolol, brimonidine, dorzolamide, and of course, latanoprost. Pressure's pretty high, actually. This is not as common anymore, but 39 in the right eye, 32 left eye on meds. So this is on meds, everybody. So no previous surgeries at all. Father with glaucoma, had glaucoma surgery, but still can see. So the father is still doing okay after surgery. I think he had a trabeculectomy many years ago. Visual field shows an inferior defect in right eye, arcuate defect, MD of -7. Left eye was pretty full still, but MD was -0.5. Ratio of cup disc ratio was 0.8 right eye, 0.6 left eye. So right eye worse glaucoma than left eye, more loss of field, more cupping. Open angles, had an early cataract, vision still 20/20, a little bit of some bat testing down to 20/40, but patient's happy otherwise. A little bit of injection, and he's definitely admits that drops aren't ideal for him. So, I mean, just what do you guys, before we go into the polling questions, what do you think of this guy in your practice? What would you do? What are your thoughts? I know you don't have the fields, you don't have the GCC and OCT with you. I know it's hard, but what are your thoughts in general? Aaron?
I guess one other question too is how long has he been on the drops?
Oh, good question. It's been about a year.
Yeah. So he's, I mean, and consider in the lifetime of a glaucoma patient, pretty drop naive, even though they don't have a great response. He's not down to physiologic under 21 pressure. My biggest concern is that he's going to progress, especially with his dad. He's needed a trabeculectomy, which in my mind means that at some point his dad has had severe field loss. It's for someone else to sign him up for a trab. And so this is the perfect time to intervene to get that pressure down. And in a young patient who is phakic, I would at least start with the angle and tell the patient that there's a high chance that later in your life, you're still quite young, we're going to have to do a trabecular bypass procedure. But right now, I'm going to start angle-based procedure. We know GATs work better in young patients that are more drop naive. So this is the time to get that pressure reduction there. He might need to stay on 1 or 2 drops, but we'll find the one that he's the least reactive to.
Nice. Oh yeah. What are you, Arkady? What do you think, bud?
Yeah, yeah. So, I think the art of glaucoma is exactly what Aaron mentioned. Kind of like who are the ones we need to be more concerned about, like the diagnostics, the predictive, prognosis. This is someone who I'm extremely scared for now. This is someone who is at extremely high risk of blindness in their lifetime. They're young. They're in their 50s. He's got a strong family history. And look at those pressures. It is not every day where you see that many medicines and still a pressure that high. So yeah, I think this is someone who I'm very concerned for. I'm actually gonna think that for the right eye, I would argue that's probably going to need to go beyond the angle. When you see a scotoma and pressures that high, the odds of getting pressures, greater than 50% IOP reduction, which is what we'd want for this patient, is, I think, going to be tough. So I think the right eye is going to need something more aggressive, like a blood-based, and the left eye, I think, would be a fantastic candidate for something, angle-based. But this is a tough case you've got. I'm glad you got this, Paul, and not
Yeah, no, they come to you guys just as often. So great points. I want to dovetail off of that a little bit. When you have a discussion with the patient, I think we definitely know surgical is needed. So I don't think there's any question there. What are you telling the patient? What's your goals with this patient? I mean, we always talk about this new world of interventional glaucoma that now it's you're in your mind. You're like, okay, if I'm taking someone to surgery, is my goal get them off of drops and keep the pressure the same? And my goal is just to get them pressures down. I don't care if they're back on drops. Is my goal do both? What do you in this kind of patient who's that high on meds? What are your goals? What are you telling him? What's your goals?
I think it's always nice to get patients off of drops, but I do think that sometimes an unrealistic realistic expectation that we've set for ourselves is that it's only considered success if they're off medications. And I tell my patients a lot of times that this is going to be complementary to the drops that you already take. My goal is it'd be great if you could get off some of them, but I would be very surprised if they got off of all of their medications just from, in my mind, an angle-based procedure that I was talking about. Blood-based, I think definitely you can get them off of drops, but in the future they might need to go back on drops, and that could be some disappointment. So I always tell patients the goal is to have a good pressure, and that's plus or minus drops.
Yeah, the whole concept of getting people off drops really came and stemmed from stable glaucoma undergoing cataract surgery, and then MIGS became kind of this big deal where we can get people off meds. When there's refractory glaucoma, all that goes out the window. I rarely, it's a bonus, but I rarely talk about getting off meds. It's, your pressures are high on meds. What we're trying to do is get your pressure lower. And I never try to push the whole, and get off meds. I'll say possibly, but yeah, you never, as Aaron said, you don't want them to think about getting off meds as their success, criteria, because that's has happened before where, pressures are 18 post MIGS or post GAT, let's say, but they're still on 4 meds. To me, that's the patient's doing better, but the patient's not happy, right? So I think, for a stable glaucoma patient, borderline pressures, I harp on the medicines, or especially someone who's just not even, like if this guy was not using his medications, then that's a different story. We talk about, how it'd be better for him because he'd be off medicine. But he's using his meds and his pressure's that high. Forget about the medications. You're going blind. You need pressures lower, and that's what we focus on.
I love that idea because it's funny. I've been known to talk about my goals to get people off of meds, I hate meds, the usual thing. But I think I've found myself getting screwed sometimes too, where I'm like, Paul, stop that. I mean, the goal for this patient is get the pressures down. If they're on meds, but you avoid a trab and the pressures, yeah, absolutely, that's success. And so exactly, that's what's important for us to kind of think about before we talk to a patient. Kind of what are we really trying to do? And what realistically can we do for the patient? So it's a really good point. And you made a good point about is this patient taking meds? Well, what do you think, in your opinion, someone a young guy on 4 topical meds, generics? What do you think his compliance really is? Do you think consolidating meds would be even an option for this guy in any way?
I bet he's good with his morning drops, but I bet he forgets those nighttime ones. And that's knowing from personal experience. Do not prescribe a medication for me to take before bed because I won't take it.
It is too hard.
At face value, I would say this is just a refractory advanced glaucoma. In other words, not an advanced, but a refractory case, and I'm going to assume he's taking his meds. But after a procedure, so we focus on a procedure, but afterwards, absolutely, we're going to make this guy's life a lot easier. Let's do a COSOP, maybe a Rocklatan, get him on less bottles based on what MIGs we do. But like right now, I wouldn't be talking about consolidating. I'd be talking about surgery.
Yeah, when that pressure's that high, you definitely got to do
Yeah.
something surgical. Okay, no, that's good points as well, and we'll talk more about drops and education afterwards as well. But so yeah, it's interesting. I think that for me, I definitely think the reduction of IOP is the key. Now, you made a good point. So, Aaron, you like the angle, and Arkady, you were saying probably need a subconj. Would you split it? So, Aaron, would you think, hey, let's do subconj? The reason why is because the drop burden reduction. I think you're absolutely right. I think when you have someone who has significantly high pressures on multiple meds, even if their field loss is minimum, even if they're pre-parametric, they can have more advanced resistance of glaucoma, resistance to outflow, despite having overall mild glaucoma from a field loss perspective. And when you have that resistance being so high, if you have that high pressure, the risk of you being, or the ability for getting off of drops from a conventional procedure, conventional alpha surgery, is just not that high. So if the goal was to get the person off of drops, then I think that you're probably not going to get there with a conventional, no matter how good you do 360 GAT even. That's where maybe a subconj might get you there, right? So would you, so Arkady, I'm asking you first. So you were saying the right eye needed a subconj, left eye not sure. Would you do a subconj in both eyes just because you want to get them off
No,
both eyes?
no. I think the left eye. So for the right eye, I mean, the case where I would do like an angle based is patients on 4 meds, pressures like 20, right? And so in those cases, you could, I think you could argue you'd be able to get off meds and lower some pressure. But with pressure being that high and on max drops, I think, like you said, with that amount of resistance and that amount of dysfunction, we just got to bypass. That's how I feel about it. In the left eye, he's got no field damage. To me personally, field and ganglion cell are the 2 things I look at to predict how well an angle is going to do. Angle-based surgery. It's just kind of some part of me, the gestalt of it. But if I see a lot of ganglion cell loss or a field loss, I'm going to already think, this is probably not going to be a great case. I could still consider it. I could counsel the patient and go, look, we could try this as a stepping stone, but these are the potential outcomes, or we go straight to the subconj. In the left eye's field is full. If we assume that he's still got some good ganglion cell and RNFL, I don't see why we would jump to subconj. I think he's got a 0.65 nerve. I think this is a home run for an angle-based trabeculotomy or an iStent Infinite, and especially coupling with drug delivery because of all this med. So no, I wouldn't do subconj in the left eye.
So let's focus on the left eye real quick because both of you agree with that first before we go to the right eye. So Aaron, do you feel like you need to do a GAT, or to Arkady's point, what about doing like a minimally invasive, like three stents and an Infinite with an iDose or something like that? I mean, do you feel like you need to do a cutting procedure to get the efficacy you need? I'm curious. No
I
right or
do
wrong.
think, yeah, I do think in a young patient, unroofing as much trabecular meshwork as we can is ideal. In my hands personally, I haven't had much success on the stents in my younger patients. I've had some who have done okay, but again, those are patients with lower pressures, not up in the 30s. So in this case, I would always go 360 with a GAT.
Yeah, actually, I'll feed on that. I mean, yeah, I agree. I think in this case, with a super high pressure, unroofing the trabecular meshwork is probably going to be more efficacious than iStent.
So when you hear people talk about, well, the TM serves a purpose, Murray Johnson, unfortunately he passed away, but he, talked about how there's a pump mechanism and there's, it filters out, debris and waste and all that good stuff. What do you think of that philosophy and that kind of pushback to cutting in general? Say, should we leave some TM behind, do like a 180 or a 210, goniotomy. Anyone comment on that?
Yeah, I mean, I'd like to comment on the two parts of that. So, number one is I think we don't know the truth of that in terms of someone who's already got refractory glaucoma versus someone who's got mild or healthy TM, right? I don't know which eyes Murray Johnson looked at in terms of the pump mechanism, but I would imagine that that pump mechanism is shot. And the idea that an eye stent will rejuvenate that, I don't know, that might be tough. I think at that point, you just remove what you can in terms of resistance, which is the trabecular meshwork, and do your best. But I will say the 360 seems like overkill. I don't know that there's any evidence that suggests that 360 degrees is necessary. I have gone pretty much in all my patients 180 degrees. And I think there was a paper out, in the past year that looked at, I don't know, four clock hours versus 12, and 4 clock hours seem to be just fine.
Yeah, there's a law of diminishing returns on when you open up more and more TM. Do you get that much more flow? And I think we're seeing that there may not be, but you don't know which 4 o'clock hours. So sometimes, and that's the conundrum we have. So Aaron, what are your thoughts on that? 180, 360? Do you feel like you need to go 360, or would you say, yeah, you could probably get away with 180?
Well, I guess the point here is I'm in an academic center, so a lot of my fellows are only getting 200, 250 degrees. I
Anyway,
think oftentimes we don't get a full 360. So I probably sign people up for 360 and are closer to, 250 degrees and not getting the full 360. But and this is maybe just, all glaucoma specialists we're extremely pessimistic that what we're going to do is probably not going to work. So we're planning the next surgery is if I didn't try to go 360 and I just did 180 in my mind, I would say maybe, like you said, Paul, did I not target the right, outflows? Did I not get the right collector channels? If I would have gone the other 180, could it have made a difference? I don't have a high rate of hyphemas since I do most of these pre-phaco, so that I have a pretty low rate of hyphemas. So I would go 360 if I can.
And are you doing it with a suture GAD or Omni or Via, or what are you doing?
A suture gap most often, just to teach the fellows that they get Omni experience with one of the other attendings, but both Omni or sutured gap.
yeah. And there's also like the lighted tip for the eye tract and VIA. There's a lot of options now for all the surgeons out there. So, but I think that definitely, there's definitely a lot more work to be able to understand is even with the 360, why do these people not, you think if it's all the TM, then why would the pressures not come down on some of these people? And that's where the whole episcleral system and, atrophy of that whole outfit, even the plexus, we don't know. So this is where we're still kind of figuring this stuff out. Let me ask you this, looking at some of the audience participation questions, I think most of the audience did agree that we want to get the pressures down, but there's a lot of them who said, I want the burden of that drop reduction. So whether it's Instagram, Twitter, X slash, or LinkedIn, everybody was like, my goal is to reduce IOP and reduce the drop burden. That was interesting because I think, we talked about how the drop burden, it would be nice, but to do that with a conventional outflow MIGS is going to be tough. And that's where maybe subconj. So I think if your really goal is that's your main goal, if the patient's like, I cannot take drops, then I think a subconj probably would be like do like a subconj MIBS, like a Zen or something like that, or an Aquaflow now that came out, something like that to maybe reduce the IOP and a drop burden as well. But there's some other questions here, other answers I thought was interesting. SLT and drug delivery. There's about a quarter of the audience on Instagram that as well, and I think just on Instagram, who said SLT and drug delivery. Here's the question: if you're already that high, would you risk SLT and a spike from SLT?
I would not.
Yeah.
No.
No, and also even if best case scenario, right? You get what you want from SLT, which is like 30% pressure, which you probably wouldn't with all this medicine. You're still not going to be controlled, right? This, especially in the right eye. So no, I wouldn't go for an SLT in this case.
Yeah. What about the left eye? What about the left eye? Would you do like a drug, like put a little Durista in there, and then maybe a SLT and see if you can decrease the?
I think it wouldn't be wrong to, because it's a milder eye. There's more time, and you could go more stepwise. It's 0.65 nerve. I just think expectations need to be placed appropriately. That for someone maybe afraid of doing something more invasive, we could try an SLT, but I can't imagine it both lowering pressure and reducing drop burden.
I think it'd be a nice option while you're working on the right eye if you do go subconj and try to find the ideal pressure, especially if you do a Zen and you might need to needle postoperatively. It's nice to have at least a Durista or something else working on that left eye while you're getting the right eye situated.
Yeah, yeah. I think in that left eye definitely, and I would probably put the Durista in first because I mean, if a compliance is an issue, we put that in first, prevent the spike, from the SLT as well potentially. But yeah, I'm always worried about spikes for those kind of high.
But that's if compliance is an issue, right? So, for example,
If
I've seen some doctors, think that Durista may work better, and they'll take these refractory patients, put a Durista in them, and I'm just like, So, I think when you have a refractory patient, pressures are high. That's not where drug delivery belongs. I would push more toward interventional stuff.
The
yeah.
only benefit's the AC tap to help lower the pressure
That's
for a
true.
little bit
That's
when you
For
put
exactly
that
those 60,
Durist in.
60 minutes, yeah.
There you
Yeah.
go. But that's a really good point. That it is true, yeah. Because a lot of people are like, hey, I put my Durista in there, my pressure's still the same as it was when on topical X, Y, and Z. I'm like, that's because it's supposed to be the same. It's supposed to be
Yeah.
about
That's right.
30%. So good question. Another question I want to ask you that we asked the audience too is really about what about the lens? So this patient, is 2020 officially, bats down to 2040, wasn't complaining, but would you say, hey, we're already going in there for my, my GAT or whatever you're gonna do? Let's just take out the lens. So you said you did your before phaco. What are your thoughts on take out the lens? Would you convince a guy to do that, or say, yeah, your vision's till 2020. Let's leave it alone?
I thought this was the most interesting from the audience responses. It was probably about a third, a third, and a third for most of the platforms on people leaving the lens, only taking it out because it would help with their MIGs, or taking it out. In this case, I think he's 57, so he doesn't have any accommodation anymore. So it's a much easier decision than if he was in his 40s. I personally would take out the lens when I do my MIGs, because then when I need to do my subconj procedure, I don't have a phakic patient that then potentially, if you combine that with a subconj procedure in the future, would have less success of that subconj procedure. And then you also don't want to have to do a phaco if you have a trab in the eye down the road as well.
I'm huge on cat migs. This is a case where I probably wouldn't, believe it or not. I'm like pushing people because I agree. I mean, it's nice to just go ahead and do like a trabeculotomy with a cataract and have an open angle in case you need to then put a tube in. But if I do a cataract in the right eye, I mean, I've already decided I want to do a subconj. I don't feel that subconj procedures do very well, especially like a Zen when you do it with the time of cataract surgery. They're 57. They're at least possibly 10 years away from needing real cataract surgery. And so, in my mind, the right eye, I think gets just a Zen or subconj bleb standalone. The left eye, I similarly wouldn't do a cataract surgery because, the option number two, where it says yes, just to feel comfortable working the angle. I mean, I think that's true for patients who, maybe are plano or hyperopes and maybe small eyes. This guy's a -6. That's going to be a deep angle. There really shouldn't be any need to try to deepen it further with cataract surgery in terms of that option. And I don't want to cause too much anisometropia. So no, I would actually not elect to remove the cataract in this patient. I've seen some 50-year-olds do have a little bit of accommodation, and if they're not really complaining, good vision at near, and now you put a lens in their eye, and then maybe that reduces some of their amplitude of vision from removing the accommodation. You just get some patients that aren't always that happy.
Yeah, no, and this is the beautiful thing about glaucoma, and it's, both of you guys are right in your explanations. Last couple questions, I'm going to tell you what I did, but last couple questions I have for you guys is: so what is your target pressure for each eye? Like, what would you be happy with, range wise?
I'd probably say right eye 18 or below, left eye 21 or below.
Yeah, I'd be a little more aggressive. I'd say under 17, so 16 and under in the right eye, and 18 and under in the left eye.
Yeah, I was thinking middle teens right eye, upper teens left eye, but yeah, I mean it's a range, and compared to where he started from, I mean, yeah, if it was 21, I would still be happier, no doubt, in that left eye. So, yeah, any other thoughts? I'll tell you what I did. We could talk about it, but any other thoughts on this case, and any other thing you want to bring up for the audience before we talk about what I did?
I would just say probably the most important thing for any doctor to talk to this kind of patient is counseling before you start. Just let them know that this may be a multi-step type of procedure where we would do one thing, and if it doesn't work, you may need another thing, and just kind of guiding them, because it's going to be hard to get a home run in a young 57-year-old with that high of a pressure. Their conj is going to be more, pro-fibrotic with how young they are. They've got a strong family history, so they may have even more refractory type of tissues. They have super high pressures. Their angle may not be that immediate. This is a tough case.
Yeah, no, it really is, and I'm glad you brought that up because I think one of the key tenets to interventional glaucoma and the discussion with the patient is to have that discussion. This is a journey, and I have a lot of options. We're not stuck with one option, and any one option may not be the answer for you. We're going to slowly do what we think is best for you and keep it the highest quality of life, but still be aggressive to prevent you from losing vision. But we may have to do something more, and then after that we have to do something more. And I think setting that up in the beginning, then you're not so scared of, oh my God, if it doesn't do enough, oh no, what have I done now? And last thing, I put it on the patient. I say, hey, if this next procedure doesn't do enough, your anatomy might be one of those anatomies where it just doesn't work with you. I put it back on the patient. Like,
Yes,
Yeah.
yes.
it is true. I mean, assuming we all do a good job and we all do the right thing, it's just like, yeah, your anatomy. It's not, it's not the device. It's not my procedure. it's your anatomy, and that kind of decreases the stress level. Oh no, we didn't perform enough for our patients. We all want to do well for our patients, and that's always that stress level. I think going into surgery, and I'm glad you brought that up, Arkady. What are any thoughts on this case?
I think it is just fun to chat and see how varying different ways that other people do. And that's why Survey Says and glaucoma is a lot of fun, as opposed to if it was maybe just a retina topic, we would just all say VEGF. So I think that exactly. I think that shows just how, as long as you are sound and have a reason why you chose that for yourself, to all of our listeners, that you're doing the right thing for the patient that's in front of you. So just make sure that, like you said, sit down and talk to the patient. I always say, welcome to the family. I'm going to be seeing a lot of you, and we're going to get to know each other over these next 5, 10, 15 years. I think that goes a long way, just saying, hey, this is going to be a long road, but we're here together.
Now that's a beautiful point. I totally agree with you. And I think we're seeing now that we the key is just not being complacent, not waiting. Whatever you do, just do something to get these patients, protected. And if you have to do something later on, fine. So great points, guys. What I did is basically, I think I followed Arkady a little bit more. I did a subconj. I didn't do cataract surgery. I did subconj. I did a Zen right eye, and then I did a GAT. I did eye track, and then I did a GAT with that in the left eye. Just try to flush everything out, and then just try to do as much of a GAT. I probably did around 270 or so, because it's hard for me to get 360 as much with the eye track, but I was pretty close. But yeah, so I mean, he did really well. So he's off meds on the right eye, pressure in the low to middle teens, around 14, 15. Left eye, he's on meds. He's on a PGA. His pressure's around 18. So he's doing well. He's back on a med, and that's cool. I'm okay with that with one eye. And I was thinking about cataract surgery, and I was thinking, you know what, with the Zen, and I have taken a lens out, and with the scarring, fibrosis, and being a high myope, I've seen sudden decompressions, even if the pressure goes down to like 10. I've seen some choroidals and some pretty bad, some pretty bad patients, even with the Zen. I'm not sure if you guys seen that. That sudden decompression.
Definitely.
And so I thought, let me just keep the lens in for now and see what happens. And if I'm going to keep the lens in my right eye, well, let's just keep the lens in the left eye because of the anisotropia. And I can always go back and do something later on if I need to. So that was the idea behind it. I was happy keeping the patient on a drop, and that's it. And then the left eye, actually, it was more of a drop and a half. It's on Rocklatan. So 2 drops, two meds. But
that's great.
But yeah, man, I mean, and that's the thing. And he knows that he's going to probably have to do something later on. We'll see how long. I'm probably have to needle him, I'm sure, but that's okay. That's okay. I mean, needling, think about it. If you get so stressed out about needling, it's an easy procedure. You get reimbursed for it, and it works for the majority of the time, especially if you don't have that flat, completely contracted conj. If it's just, thick and tenon, just loosen it up a little bit there, revise it if you have to. But
I mean, that's a fantastic outcome in the right eye. I mean, so usually for some of my Zens, I mean, they'll still need to be on a drop or so because, those conj gets a little hypertensive around the bleb, but that's an amazing outcome.
I did tenonectomy a little bit too as well. So the thing that I worry about that, when I do a tenonectomy for these younger people, I do sometimes get that ring of steel too, though. You got to be really careful about that. So I was really aggressive. I mean, I kind of think I should show the video, a little too aggressive with the tenonectomy, and he still pressures the middle teens, but I was just like, remove everything, man. But you got to be careful about that kind of ring of steel after you do a little tenonectomy. But yeah, I mean, left eye back on meds, and that's okay. I'm actually happy with that, and we'll see what happens. This is a long-term journey for everybody. So, but no, this is a great case. I want to thank the audience. First of all, thank you too. I mean, this is a great discussion. It keeps me so pumped when I get to hang out with my friends and colleagues and learn from you guys, and just realize we're all doing the same thing, all working on the same issues and barriers, and we're not
Makes
alone.
You feel better. Yeah,
it's like therapy session for me. Yes. It's like a half an hour there. So thanks for my free therapy, guys.
Every time.
Appreciate it.
Absolutely.
But I want to thank the audience too, thank you for listening. Thank you for paying attention. And also thank you for contributing and going to those social media posts and really and getting involved, because it really helps kind of keep these episodes going and really learn from everybody out there. And hopefully until the next time, stay healthy and take care, everybody. We'll see you soon.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.